there are different techniques of instrument manipulation, but importantly, when we are dealing with the primary teeth, we need to be seeing some of the techniques which fits in particularly for the primary teeth. The usual instrumentation techniques, what has been followed is the watch binding and the circumferential filing, anticurvature filing. That is what we are going to discuss in detail a little bit, and a balanced force technique. So, when we come to the circumferential filing, it is done with the headstone file. It is apical, the working length is kept 1 to 1.5 millimeter short of the radiographic apex. And the circumferential, it continues with the back and forth motion with a slight apical pressure. Each slight turn engages the flutes of the dentine in the canal wall and removes the dentine. Once the file has reached the desired length, that is by a watch binding technique, once you reach to the desired length, then push and pull filing action is used. As the headstrong file, that is H files, are most commonly efficient for circumferential, that to particular full inner straight canals. So whenever we have the primary teeth and molars particularly, we have another problem encountered apart from the tortuosity of the canals and the ribbon-shaped canals, that is the developing tooth bird in the furcation area, or that usually causes the resorption in the inner aspect of the roots. And at the same time, the resorption which usually been seen here with the routine instrumentation, if we carry out with either a circumferential filing and other instrumentation technique, there is a chances of strip perforation. To avoid this, we have to have this particular technique, which we are going to force the instrument, that is the force which has been applied while while instrument activation is away from the curvature. That is why it is called as an anti-curvature filing. As this arrow indicates, the instrument is pushed away from the curvature or the opposite side of the curvature, and the instrumentation is done with the instrumentation technique, what has to be given to that particular instrument. Okay, and that is what is done particularly to prevent the strip perforations. Now there is an anti-curvature filing which has been given. This is given by Aburas and involves the filing predominantly away from the inner curvature of the root to reduce the risk of strip perforation, and used in the canals with moderately severe curved canals. But if the curved canals are more severe, we need to go for a balanced force technique. In this, we are going to give a 60-degree quarter turn, 60-degree clockwise turn. It is less than a quarter turn. Just remember, it is less than 90 degrees. It is just a 60-degree clockwise turn and 360-degree anti-clockwise. How it is being done? Once then you introduce the instrument into the canal, that is a K file or instrument which has been, when a slight resistance is felt, when it has been introduced and a slight resistance has been felt, and the instrument is rotated clockwise 60 degrees, and we don't allow the instrument to come out with an apical pressure which has been placed by the finger, and it is rotated anti-clockwise 270 to 360 degree turns so that it cuts away the dentine. And the instrument is taken out, cleaned, and again irrigated into the canal, because every step of the instrumentation we have to irrigate the canals. So once it is being done, and further step till we reach to the desired working length, this technique will helpful. And one of the things what we need to have in a severe curved canals, that is a super elastic material, that is NITI instrument, and non-cutting tip is a mandatory one. So this balance force technique, which has been described by Roy et al., it is particularly good when negotiating a curved root canal. Requires flexible files and non-cutting tips. The file is inserted into the canal until there is slight resistance is felt, and then rotated to the 60-degree clockwise to engage into the flutes, into the dentine. And later the file is then rotated to 360 degree in a counterclockwise direction, and not allowing the instrument to come out. Whenever you engage the dentine, if you allow the instrument to come out, there is no cutting of the dentine which is going to take place. This movement picks up the dentine into the fluids of the file, and using this method, curved canals may be prepared to the full working length without producing apical transportation. So, root canal irrigants, what I was talking, copious irrigation of the root canals is performed at each and every step of the root canal preparation. So, there are various root canal irrigants which have been used: normal saline, hydrogen peroxide, ethylating agents like EDTA, chlorhexidine 2%, 5.2% sodium hypochlorite. The particular importance of sodium hypochlorite is that it has got a tissue dissolvent property. It has got a good antimicrobial property. Even for the primary teeth, which has been recommended by the guidelines, is 1% of sodium hypochlorite is also enough, and good results with 2.5% of sodium hypochlorite has been seen. And the temperature also plays a very important role when we are irrigating with a sodium hypochlorite. And another important thing what we need to consider here is an agitation of the intracanal irrigation. That is ultrasonic or sonic agitation found to be the better ones. That is, the ultrasound has been used to activate specially designed endodontic files. The acoustic energy is transmitted to the root canals instrument, which is oscillates at 20,000 to 40,000 cycles per second. Irrigation with sodium hypochlorite is necessary. The superior cleaning effect is achieved by acoustic streaming of the irrigant. So, ideal requirements of these with this irrigation and disinfection of the canal which has been taken place, then we need to dry the canals, and we need to have the root canals to be obturated or filled. So there are certain ideal requirements of these root canal filling materials what we need to consider. Those are the first and foremost, it should be resorbable when we are talking for the primary teeth. And it should adhere to the wall, should show no shrinkage. It should be radio opaque so that it can be visualized on the radiographs. No discoloration of the tooth, harmless to the periapical tissues and permanent tooth buds if accidentally it has been extruded out. Or it should have an antiseptic property and easily filled into the root canal system and even easily removed when it has to be taken out from the canals. Root canal filling materials, there are n number of root canal filling materials which are available, but previously what they used to use is the zinc oxidizole. It has a long standing history of its own, and for calcium hydroxide is being used. Combinations of calcium hydroxide with iodoform like Vitapex, even iodoform has been used, Volkov paste, KRI paste, mastose paste, endofloss, even bone morphogenetic proteins have been used as a root canal filling materials. There are certain compositions which have been given in your textbooks also, like Volkov paste, KRI paste, mastose paste. These are the iodoform based paste, and parachlorophenol, camphor, with variations in their proportions, right? And mastose paste has got a zinc oxide along with other constituents like iodoform and parachlorophenol. So, the newer root canal filling materials nowadays, the most popular one being the combinations of calcium hydroxide and iodoform, like Vitapex and Metapex. They have got their own advantages like resorption from the apical tissues and the furcation areas if they have been accidentally extruded from the canals. Not so hard in consistency, so removal is easy. If necessary, they have got their antibacterial or antimicrobial action. However, their resorption has seemed to be faster than that of the roots itself. That is the major drawback with this thing. And it has been forward with the addition of zinc oxide to this combination. That is the calcium hydroxide with the iodoform paste along with the zinc oxidizole in endofloss. It is also been recommended for an endodontic filling materials for the primary teeth. So then coming to the obturation techniques. The obturation of the primary teeth are done with various techniques like spiral root canal fillers, which has been given by Costagnula, and pressure syringe technique, which is being given by Greenbow, lentillospiral technique given by the Coppel, moist cotton pellet, endodontic pressure syringes. Even nowadays, the materials coming into the syringes, and other techniques like given by the McDonald, like coating the canal walls with a thin constant thin mixture of zinc oxide additional with paper points, and then filling by K-files and RC pluggers. And another thing which has been given by the Mathewson, the endodontic filling material, which has been used with an amalgam plugger, file, and also using coat to coat the canals with a paper point, and moist cotton pellets to be used. Usually with an hand instruments, we usually follow an incremental technique. In that, what we are going to use is a reamer, particularly the reamer in an anti-clockwise direction, which has been used. Push motion and anti-clockwise direction of a reamer is going to obturate the canals in an incremental fashion from apical region to the middle region to the coronal region. It has to be done. And other techniques like an endodontic plugger is used to push the endodontic filling material. In this slide, it has been written as zinc oxide additional as an endodontic material. So wet cotton pellet can also be used. And endodontic pressure syringe, particularly designed for obturation of the canals with the zinc oxide additional. Here, every quarter turn, we are going to pull the syringe back, which has got a thin, flexible syringe needles, which will come with the pressure syringe, and thereof even 30 gauge needles. And they go till the apex, but we need to keep it short of the apex, give a quarter turn, obturate that particular portion, come back, and never ever allow the needle to come out of the obturating material so that the voids in the obturation can be prevented. Then it is finally been restored with a stainless steel crown. So these are some of the radiographs, pre-operative and post-operative root canal obturation in the primary molars. Then when we were discussing about the zinc oxide additional, there are some long-term disadvantages which are associated with it. Even though it has been used extensively for so many decades, the chances of retention of overfilled material in the apical region has been seen. And retention of zinc oxide additional can cause difficulty in normal root resorption and easy eruption of the permanent teeth. And even it has been seen some of the mild foreign body reactions. So we have a calcium hydroxide material, majoritarily used nowadays for obturation of the primary teeth and their combination. They have got their own advantages, like no evidence of internal resorption of the teeth has been seen, no deflection in the eruption of the premolar, resorption of the over-retained extended material, not the premolar, it is a successor particularly. There is no deflection in the eruption of the successor tooth. Resorption of the overextended material, which is fast. Within 3 months, you can see that the extruded material is resolved by the body. Healing of periapical radiolucencing in the permanent teeth has been seen. The rate of resorption of the material from within the canals is faster than that of the physiological root resorption. That